my name is Dr. Caitlin Regner, and I did family medicine residency here at UW, and actually trained in care of pregnant people with substance use disorder with Dr. Atluru, and then also did some training by virtue of being housed sort of within the Winger Clinic, training with the Health Promotions Clinic. So it was really helpful to have their input and their guidance and expertise as well. And I currently work at Access Community Health Centers and provide care for both pregnant and non-pregnant patients with substance use disorders. Do you want to have others go around and just briefly introduce themselves?
Well, I'm so glad that you guys are here tonight. I think that this is a topic that you guys do really uniquely. There's not many people in town here. I think you guys might be the only two that actually treat patients who are doing their prenatal care as well as their prescribing their buprenorphine. So it really is just the way that healthcare should be. It really just limits office visits, and patients can be able to see one person that they feel comfortable with. So I really applaud you guys for doing this work because it's very needed. So thank you for being here.
I'd love to hear from others who are here on the call who want to just maybe introduce themselves and their current role with the opioid or other substance use, whatever role you have with interacting with people who have substance use disorders, and how you're what you're maybe even hoping to learn from this.
I can share. Hi, I'm Heather. Can you hear me okay? Okay, I have my headphones on. Well, my kids are in the other room. I'm a certified peer specialist and parent peer specialist, and I'm in Milwaukee County. And previously I was involved with ED2 in Milwaukee at WCS, and I've shifted my role into CCS work in Milwaukee County, and my focus is actually pregnant people. And I have my own experiences, and so I'm just really particularly interested in this because I've been looking for providers who maybe work with pregnant people who have substance use issues like harm reduction and medication. I haven't really been able to find anybody, so I'm just really excited to learn more today and listen in and hopefully continue to connect.
So it's very interesting that you're in Milwaukee, but Patrick, I'll let you.
No, I just wanted to say, I do the peer support specialist recovery coach training with the Recovery Center, but I do also do the CCS through the county. And I think one of the things we work with a lot is pregnant women and kids, and it's kind of like accepted in the recovery community, but not really talked about. We don't really know, like it's there, but we kind of just but we pretend like it's not. I don't really know how to explain it. But I'm really excited that this is here. I think this is something that needs to be talked about, and I'm really excited for this.
Should we rock and roll, Dr. Regner? Or is there anybody else on the call? Caitlin, I see you. Cole. And
yeah, I'll just quick say I'm a RN care coordinator with the Hub and Spoke program with UW Health, and work closely with Dr. Atluru and Dr. Miller. So I've already learned a lot and looking forward to learning more through this.
Awesome. All right. Well, thank you everyone for your support. I mean, I think one of the things that we all have experienced and know is that it really takes a lot of people and a lot of support in many different facets of someone's care to help them achieve recovery and continue to be successful in recovery. And so I think just everyone's presence here really demonstrates that. So I'm going to go ahead and let Dr. Atluru start us off here.
So I'm very sorry to people who joined the call. I have laryngitis, so I'm going to probably not talk a lot, but We have no relevant financial disclosures as part of our UW-Madison School of Medicine and Public Health byline, so sorry. These are kind of our objectives. So I think just making sure that we understand reproductive age individuals, and I think people, and what the medical field refers to as reproductive age is anybody that has a uterus who could potentially achieve a pregnancy. So that could be anywhere from age 10, 11, all the way up to age 50. And then to connect people who are of reproductive age, who maybe choose to continue with their pregnancy or not, there's no judgment, to high quality evidence-based care, and then to engage and provide equitable care for people with substance use disorders in pregnancy. I saw one of our peer support specialists from Safe Communities join. But we can go on to the next slide. I actually really like this. I don't know if anybody has this. It's the Perinatal Harm Reduction Toolkit. It was developed by Dr. Mishka Turplin and several well-renowned individuals, at least in the medical field, around destigmatizing language. I always ask patients what they like to be called. I don't usually use the word pronoun. I don't usually use the words. I'm like, hey, what do you like to be called? Because somebody may have the name, like, my name is Sreevalli, and I go by Sree with people that I know. So I would just ask people what they like to be called. And this is something that Dr. Regner and I teach our residents and it's really in our medical students, and kind of, we try to avoid language that's not person first language. That's because I think the medical field has contributed obviously a lot to the development of addiction medicine and the development of opioid use disorders in many ways. And then we stigmatize people. So I usually, it's hard. I think we're trained in medical school to use words like addict or abuser or junkie, but those aren't actually words that are used in the medical literature. There's no idea. We have to bill, and our lives are over on insurance. And so there's no billing diagnosis for opioid abuse. That just doesn't exist. So why are we using the language that is not actually medically appropriate? And so, and the words such as got clean, I usually mimic what patients do, but I talk to them about the language that they're using, because I think there is a lot of shaming language, especially I help care for people in the correctional system. About getting clean. But I also think the other thing that's important is, and just to emphasize this too, is newborns can't be born addicted. They don't have the physiologic pathways for addiction. And so when I see things in social worker notes, in care community notes that say child born addicted or dependent on opioids, that's actually factually incorrect. And it's not something that can be billed. It's not something that's actually appropriate. Those pathways don't develop until you're in your teens or 20s, when the frontal cortex of the brain actually fully develops. That's when all of the executive function comes in. And so you refer to things as a neonate with prenatal cocaine exposure. They have a exposure. They may not necessarily, they don't have the physiologic pathways for dependence. And so I think this is a really important slide. This is kind of what I use and others use. This toolkit is really nice. It's free and available online, and we put it in the website. We're happy to share our slides as a PDF. If you want to go to the next page. The other thing I think that's important is, and I'm going to just take a sip of my hot water with honey or tea, so opiates are natural opioids. So what natural means is that it's found in the environment. Heroin, which is made from poppy derivatives, morphine also made from poppy derivatives, and codeine, those are natural occurring opioids. Opioids are a kind of the overarching kind of tree They're all natural, semi-synthetic, and synthetic opioids. So natural occurring products, nature makes them. Semi-synthetic means that they're in a lab and they take different components and mix them together. And then fully synthetic means they're fully pharmacologic or manufactured. Narcotic is actually a legal and police term. It originally referred to any substance that dulled the senses and relieved pain. It's not as common. I did not train here, and so we never use narcotic. The only people that used it where I trained on the West Coast was the DEA or the police. We only use the word opioid. So this is another important thing that we kind of communicate is narcotic is a very negative association with some of my folks and clients. It also has a very negative association in the other hats that we all wear, inpatient and outpatient. And we really try to educate people and say, just use the word opioid because that encompasses everything. It doesn't have as much of a legal connection to it. But if you work for the DEA or other organizations, then it is appropriate to use the word narcotic. But opioid kind of refers to everything. So, I mean, I think we understand that untreated opioid use disorder in pregnancy is associated with different types of perinatal outcomes. Just because you use opioids doesn't mean you won't have any of these things, but also just because you use opioids doesn't mean it means that you may have exposure to these as well. And this is a kind of sobering chart about opioid use at time of delivery. Unfortunately, this graphic does contain methadone and buprenorphine, so I don't know how kind of scary it is. And urinary abstinence rates have risen in terms of treatment with morphine since the introduction and kind of the widespread use of buprenorphine as well. But I think it's just kind of what we all knew. And this is specifically for opioids. So needle opioid withdrawal syndrome is what we refer to now. And then it's over to Dr. Regner. You don't have to listen to my scratchy voice anymore.
You just have to listen to me cough. It's funny, you know, it's funny getting like any sort of, I was just thinking about this with you, Sri, or Dr. Atluru, you know, getting a cold, it's like no one's had a cold for, you know, probably over a year, right? So what an interesting experience. All right, so checking bias. I do want to give credit to the current addiction medicine fellows or current addiction medicine faculty, Dr. Egan and Dr. Salisbury Afshar. So I was first introduced to this concept from them, and I just think it's a really helpful mental exercise to go through, thinking about how do we approach our routine kind of medical patients, and then how do we approach our patients who suffer from use disorders, and why is there sometimes a disconnect, and how can we maybe kind of get over that? So this is an example. 54-year-old female is in your office, and this person has type 2 diabetes. Most recent A1C was 12, which just indicates that it's poorly controlled. So on chart review, you see that this person frequently misses appointments with providers, the nurse and the dietitian. She continues to gain weight despite many referrals to various exercise programs and encouragement for weight loss. And then she's taking a statin to help manage her cholesterol. All right, so here's an example. So what do you do with this patient who has uncontrolled diabetes and is, you know, moderately following some of your recommendations? Do you A, tell her that unless she follows your recommendations and sees the dietitian, you are going to have to discharge her from your practice and discontinue her insulin and statin and antihypertensives? Do you B, understand that her diabetes will never be controlled and decide to continue to be her provider, but just focus on other health conditions? Or C, do you try to explore barriers, celebrate her cholesterol control, and see what her goals of care might be? Now, this sort of sounds, as I'm saying this out loud, I mean, this sounds ridiculous to think that you might say to someone who has poorly controlled diabetes, well, I'm just not going to care for you anymore, or I'm just going to ignore that and we're going to talk about everything else going on in your life. But at the same time, this is sort of sometimes what we do for people with opioid use disorder, especially those who maybe don't feel comfortable providing that type of care. So let's just look at the example here. 54-year-old female, same type of scenario, who has severe opioid use disorder in primary care and receives buprenorphine from you. Urine tox screens are persistently positive for cocaine. occasionally for benzodiazepines. The last few urines have been negative for other opioids. Intermittently, she does not come to appointments and is very rarely seeing the, I can't see because of where my, here we go, therapist, as you've recommended. So what would you do for this person? Do you say that you're going to have to discharge this person from your practice and stop prescribing? Think that they're never going to achieve recovery, and so then focus on other medical aspects? Or do you explore barriers, celebrate negative opioids, and identify goals of care? Yeah, so just as in a situation where someone has diabetes and you're trying to kind of meet them halfway, understanding that, you know, their understanding of their disease, your understanding of their disease are different. Their priorities for their care and your priorities for their care might be different. Just as you might do that with any other medical problem, we really should be doing the same thing for opioid use disorder and trying to assess where people are at. You know, of course, checking ourselves and making sure that we're providing this treatment in a safe way, but checking ourselves to ensure that we are not unfairly penalizing patients who have already, in many situations, been treated poorly by both medical and legal systems. I think this is over to you, correct, Sri?
Does anybody have any questions? We didn't want to just talk at everybody, but does anybody have any questions? Otherwise, we'll keep going and maybe we'll take questions at the end. I think that'll probably be easiest. But just to highlight what Dr. Regner said too, I think I use another example of some of my folks who have heart disease where they get heart attacks. We don't tell people that they can't get their heart disease repaired. And let's say somebody comes into the hospital with a heart attack. We're not going to tell them, no, we're probably just not going to take care of you. Or, hey, we're not going to refill your cholesterol medicine and your blood pressure medicine and your aspirin. And oh, hey, by the way, I decided to stop taking these medicines and I had another mini heart attack. I have to go, you know, we're not going to tell them that they can't get their medicines. So the juxtaposition of that, I think, is really interesting. And it kind of helped open, at least when we were giving this presentation to some of our partners in family medicine and other areas of our department, it really kind of opened their eyes to say, yeah, I mean, this is work that it's like any other disease process, and just really trying to normalize that for people, because I think a lot of physicians and providers and others feel that addiction is something that somebody can control. And oftentimes, most of the time, it is not. So we talk about, oh my gosh, I'm going to start. Yeah, this is not good. Not good for my voice. So screening. So when we talk about screening, we mean, what do we do when somebody walks into our office or walks into your system or walks into your, texts you and says, hey, I'm pregnant, I need help. I always ask people how they feel about being pregnant. Sometimes pregnancy can be it is overwhelming. Otherwise it can be, sometimes for some people, it can be a turning point. For some people, it's a mixed bag of everything. And so I think it's really important to ask, how do you feel about the pregnancy? Sometimes, and I mimic patients, I mean, sometimes they refer to their fetus as a baby or a thing, and so pregnancy is just like the neutral term that I sometimes use just to kind of encompass everything. So somebody walks in and, you know, how do we ensure that we understand maybe pregnancy risk factors? So our institution at UW is going to be implementing in the next 3 months across all of primary care. So primary care is family medicine, obstetrics, and midwives groups, at least within UW, and that includes access. Universal screening. So every person, no matter their history or where they come from, will always get tested or asked about substance use disorder and pregnancy. And I think that completely destigmatizes it for people. I know some people have asked and said, why do I have to answer these questions? And I said, this is just part of the process. Welcome to pregnancy. You answer a bunch of questions when you choose to come to the medical professionals and deliver in a hospital. I mean, but I think it's actually really helpful because it does highlight, especially in Wisconsin, alcohol use disorders have been uptrending. People ask, is there pregnancy blood work? Yes, there is. Routinely, we order pregnancy labs to check your blood type, to check for low iron, to check for HIV, to check for hepatitis B, syphilis, which is rising in Dane and Milwaukee County, and then gonorrhea and chlamydia. The CDC is actually recommending, and this hepefully will help destigmatize hepatitis C screening for every pregnant person, regardless of any of their history. Everybody should get checked for hepatitis C, just given that it's everywhere. For people who may screen positive for substance use disorders in pregnancy, and either they're still actively using whatever substances they're choosing, and or they have discontinued their substance use and have switched to a medication that helps support their recovery or not. I actually consider kind of every 6-month infectious testing for inhaled or injected use. Yes, Heather, we can talk about that at the end. You're getting ahead of us. So yes, and then I always ask about a urine drug screen, and I always ask people their permission first and say, can we get a urine drug screen? If they say no, I'm like, help me understand why you don't want me to. And if they say I'm gonna have a bunch of stuff in it, I'm like, well, at least we know, because like then if you have benzos and fentanyl and I'm starting you on buprenorphine, that's probably not the best idea for your safety. So I try to frame it as a informative thing rather than a punitive thing. The next slide, Dr. Regner. For the screening form, the 5 Ps are free. They're available anywhere. And I actually like this one because I think it involves like it's harm reduction language, and it's also non-gendered. And I think of all the screening tools, this one is the one that most of us are using. And again, we can help share these slides. They aren't unfortunately available in other languages. And they're not validated, which means that they're not studied for people to be translated and then given to somebody who may speak a language different than English. Problematic? Yes, that's what we've got, unfortunately. If you want to go to the next one. And then this is the NIDA quick screen. This is what the National Institute for Drug Abuse released. And then if any of these are positive, then you go on to a more extensive screening, which are found either on the NIDA website or the 5 Ps, and we'll kind of go over that. And then I think this is important. So the American College of Obstetrics and Gynecology is the governing body for all obstetricians and gynecologists. We as family medicine doctors usually follow, who do obstetrics still follow all the ACOG guidelines. And then the American Society of Addiction Medicine, they came together. I mean, 2012 is not that long ago, to say universal screening, brief intervention, and referral for treatment help improve outcomes for people and their infants. And they also recommended opioid therapy with either methadone, buprenorphine. There's some literature about naltrexone, which we can talk about if people are interested, which is something I'm interested in. And it's preferred actually over medically supervised withdrawal. There was one study in Tennessee from a maternal fetal medicine doctor that recommended weaning people off their methadone and buprenorphine. I don't recommend that. I've had too many people relapse. But that's what they do that's what they do in some places. And then Dr. Regner will take over.
So one of the things
I have to go get some more hot water. Sorry.
Yeah, go for it. One of the things to just touch on is that in this community, there certainly are some obstetric providers that provide this care. But I would actually say that a lot of these patients end up going to family medicine, and there's several reasons for that. But part of it is that the use disorder, a lot of pregnant women who seek out care from an OBGYN see that person for the 9 months of their pregnancy and then their postpartum visit, and then they sort of, they're not really seen again until they have maybe another baby. Also, as you see here, many fewer OBGYNs have their waiver to be able to prescribe buprenorphine in the first place compared to family medicine physicians. And so the benefit of family medicine is that you have a long-term, long-standing relationship with patients. You can provide care during pre-conception, during pregnancy, afterwards, and then also we can provide care for people's babies. And so I think that there's a lot of benefit to that, and sort of what I said at the beginning about these patients need a lot of support. They need a lot of help. They need a lot of affirmation, for the really hard work that they're doing to combat their use disorders. And so being able to provide that support throughout the entire process is really beneficial. And again, also, I think just having experience with managing patients on buprenorphine in other settings does lend to family medicine providers being a little bit more comfortable, I guess, or more adept at managing, difficulties as they arise, because it's probably not the first time that they've seen them in a pregnant patient. Okay, so just talking a little bit about prenatal care. Here's a case. So you have a patient, 22-year-old female, has a 9-month-old. She's not had any periods since her last delivery, and then comes in with her baby for the 9-month checkup. She asks you for a pregnancy test while she's in clinic, and it comes back positive. She wasn't planning on a pregnancy, and she's revealed to you that she is using injectable heroin daily. So how do you respond? And I think there are a lot of people who, as they're reading this, their heart's going like, what do I do? So the goal of going through this is so that there are tools and there are things that each individual can turn to, so that if you're in this scenario where someone discloses to you, first of all, I mean, that's sort of similar to any other sensitive information that our patients share with us. The first response is, wow, thank you for sharing that with me. Oftentimes, that is a hard thing to share. Thank you for sharing that with me so I can help provide the best care, for you during this pregnancy, or so I can help guide you as you make decisions moving forward with this information that you are pregnant. So we've already had positive screening. And then the next question is, how are you feeling about this positive pregnancy test, as Dr. Atluru mentioned? And I think that there can be a tendency, we don't want to corral patients in any way. We just want to, gauge where they're at. Oftentimes it's an ongoing conversation. The way someone feels about the test the first day that they see it is maybe not always the same way that they're going to feel about the test a week later, 2 weeks later. So being able to continue to engage in conversation. There were some questions when we presented this information at a meeting with other family physicians. There was sort of this assumption that someone who's using IV heroin might not want to keep a pregnancy. And that's also not correct. Just because someone has a use disorder doesn't mean that they're not thinking about planning a family and moving forward. And, that's certainly a barrier, but it doesn't mean that in many ways, it actually gives me hope that people are seeking their future, that they have plans for their future and want, whether it be having a baby or getting a job or whatever it is. To me, that's oftentimes a positive sign that someone is motivated for their recovery. So anyways, discussing options, ordering prenatal labs, which is really important, making sure that you do get hepatitis C, but as Dr. Atluru mentioned, this is something that we're screening all patients for. And I think it's helpful to normalize that, this is routine screening we do for every single person, when they are pregnant. And then arranging for follow-up. And oftentimes I'll say, being able to arrange for follow-up both medically, but then also support, whether it be, counseling or a recovery coach or someone else that can be walking along someone in their journey to seeking recovery. And then as of right now, there are a couple of other people not listed here, Dr. Bowman, and I'm not looking at the list of people, she may be on this call right now, but so Dr. Atluru, Dr. Regner, Dr. Bowman, there are a couple newer providers that are seeking to provide more of this care at both the Belleville clinics and other access clinics. So But in general, we're kind of working on triaging, and Dr. Atluru and myself, I would say, are the main people who are triaging these patients to other providers that can provide this type of care. And then this is another key one, just making sure that people are safe so that if they're using actively, they or someone who knows them, loves them, have access to naloxone.
I just also want to say, sorry, Caitlin, in regards to naloxone, there's a great video on YouTube from the manufacturer that teaches people. It's 2 minutes. I usually pull it up in clinic and I have people watch it. I give everybody who even family members, and I just, it's readily available. Medicaid pays for it now. Do you want me to talk about this one, Caitlin, Dr. Regner? Okay.
Yeah, sure. That's fine.
So I think the other important thing is that Caitlin mentioned is around pregnancy counseling. And I think just trying to figure out where people are at with being pregnant. Like she said, sometimes a pregnancy is something that can really change somebody's life and forward thinking. But sometimes it's not. And the state of Wisconsin does have strict limits on terminating pregnancies if that's something that somebody chooses to do. So making sure that they understand that if you're at a certain, however many weeks you are, you can't terminate anymore here in the state. And there are resources that I'm happy to share with you guys if you're interested. But I think that's something that should be highlighted. And some people feel ambivalent about the pregnancy until the very end of it. And that's also, that's ambivalence is a decision as well. I know we've been focusing on the Madison area. Outstate programs, just kind of looking at Milwaukee County and Waukesha County. So there are outpatient, and the new terminology that's actually being used instead of medication assisted treatment to make it more person first language is medication for specific substance use disorders, so MOUD, which is medication for opioid use disorder, medication for alcohol use disorder, just to try to normalize it, especially amongst medical professionals, so that people don't think it's a crutch. So yes, Waukesha Family Medicine, which is affiliated with UW Health in Waukesha, does the same kind of care that Dr. Regner and I do. They just do it within their family medicine residency, and they deliver at Waukesha Memorial Hospital. There aren't any other big organizations in Milwaukee that are doing it. Columbia St. Mary's and their program is doing it as well. But if you want the services, there aren't anything like MedHouse. So in Dane County, and you can refer patients, it's ARC, which is the Maternal and Infant Program, which is an 11-bed program contracted partially with the Department of Corrections and with individual counties that refer pregnant people usually in their second and third trimesters, so after 24 to 28 to 32 weeks. And they are able to parent their children if they choose. Dr. Regner and I and Dr. Bruhlman and Dr. Howlett, there's about 10 of us, I would say now, that help share their care and deliver with the family medicine residents. And they usually come see one of us for all the pediatric care. So they go to one person for everything, which is, I think, what family medicine offers over what OBGYN. And I don't want to discount anything, like we need our OB colleagues. I don't do C-sections anymore. But I think that the limits, especially in urban and suburban areas, are that you only see a patient for 10 months. The patient usually goes to a pediatrician. That's 5 appointments they have to go to. We do that in 5 visits. So the other thing that we have is we try to connect pregnant folks to the peer support specialists and all the, Becky, you can kind of intervene, but I don't want to overstate, but the peer support specialists who are affiliated with Safe Communities, Madison-Dane County, who work with pregnant women, are also all doulas. So they can be present at the hospital, which I think is really important because of the unlikely lifting of any visitor policies. We haven't lifted our visitor policies in Madison, so there's only 1 support person allowed. But because a doula is considered part of the medical team, at least at our hospital we deliver at, they kind of help support a patient in their, because it's a very intense process. It's a very triggering process for people. Yeah. And then Other resources, obviously Wisconsin Voices for Recovery. So DFMCH is the Department of Family Medicine and Community Health at UW. We assist with running the program. Dr. Miller is the medical director. And I often reach out to them or through Safe Communities to see, because I help, and Dr. Regner does too, I help care for patients from around the state. And to send them back home and to have resources back home, especially for First Nations people. And then I just think the really important thing for us as physicians is we're resource heavy in Dane County, we're resource heavy in Milwaukee County, but the right hand doesn't talk to the left hand. And so I think it's important for people to come to appointments. You're welcome in our clinics. Becky Foss is embedded in my clinic in DeForest, which is about 20 minutes north of Madison. And I think the other important thing that I tell patients, and I've seen this a lot in surrounding counties and from OBGYNs, is they scare patients off their methadone and buprenorphine, and they tell them their babies are going to be addicted. And that is just not true. And it's it's just very disheartening, because this is how people relapse during their pregnancy, and then they get incarcerated, and then their babies get taken away from them, and then the cycle just continues. And so what Dr. Regner and I really emphasize to people who come to us, especially from outside of our organization, is to understand how people can be supported who may choose not to do medication, or who choose to do medication, or who are already on medication and are I think there's a lot of stuff in the community that you should not be on this medicine. And I've just seen not good things. And it's never nice to be on the other side of that phone call as a provider. And then I'll let Dr. Regner, do you want me to do this one, or I can do this one, Caitlin? Dr. Regner, it's up to you. I feel like I'm talking a lot. Okay. So Child Protective Services, I think I just want to highlight. So the state of Wisconsin has a state statute. It's Wisconsin State Statute 292. It was called the Cocaine Mom Law colloquially. It was passed in 1992, primarily to target Black women who were using cocaine to take their children away from them. And so that law has permeated the state of Wisconsin and is still statute. And I think a lot of people are concerned and worried about this. And so that law mandates, and I think it's on the next slide too, but that law mandates that the correctional system via county district attorneys and state and city district attorneys can compel people to obtain treatment and put them on medicine without their consent. And it was a law that was made, again, like I said, to target, they won't say that, but it's made to target Black people and Black people who have babies in the 1990s, the Cocaine Mom Law. CPS development's always troublesome. I think people always are scared. How I broach it with people is, at delivery, whether you deliver in a hospital or not, we recommend these things. Serial urine drug screens during pregnancy. It's just proof to CPS that you are in recovery or that you're not. And if you're not in recovery, then what are we doing for your recovery? And that's how I present it to people, rather than as a putative thing. The reasons to consider CPS involvement antenatally or before the child or fetus newborn is delivered is serial positive drug tests without disclosure. I always tell my patients, please don't lie to me, because if this medication is like medications that I prescribe to you can kill you. So I need to know what you're doing so that I don't kill you. Or if there are concerns for safety or neglect, and that is very broad. You can notify CPS prior to delivery. They usually are overworked and they have a lot of things that are on their plate. And I'm not discounting the great work that they do. But I also think the important thing to emphasize to people who are pregnant is it's not about proving to CPS, but show them what you've done, just to say, these are the steps that I've done to have a supportive partner, or supportive family, or doula, or recovery coach. But these systems, unfortunately, have been really affected in COVID and probably continue to be as we continue to wade through this pandemic. You want to go to the next slide, Dr. Regner? So this is a state statute. So it's actually a law that enforces via court order for pregnant people to enter treatment programs without their consent. And it has incarcerated people who are pregnant. And it has been something that statutorily has been challenged in the courts. The Supreme Court of the United States has chosen not to hear it because they think it's something the legislative branch of the government should overturn. It is not something our legislatures are interested in overturning at this time. And I will go back to Dr. Regner.
Okay. So postpartum follow-up, most of the people who, I would venture to say all the people who deliver in the hospital are going to have, in addition to care from a medical team, are going to have care from nursing, opportunities for care from lactation consultants, but then also oftentimes care from social work to ensure that there are kind of proper things put in place to help encourage someone's continued sobriety or continued abstinence from substances. And I will just say that the transition from pregnancy to then delivery and postpartum, that's a really vulnerable time for people because oftentimes, depending on what someone was doing prior to delivering their baby, maybe they were working, maybe they were out and about, and now they're sort of like at home by themselves in pain. There are so many different things that can be triggering about that experience. And so I do think that it's a really important time to see our role as being just, again, surrounding someone with those who can help them maintain and be successful in their sobriety. So contacting PCP, oftentimes if it's a patient you're delivering, of course it's yourself, but your team, making sure other people are aware of like what's going on, if there are any other factors for people to be aware of. Sometimes being able to check in with both parent and infants together. There can be this in the traditional medical system, there can be this sense from the parent experience that there's all this focus on parent, pregnant, and then all of a sudden the baby comes and all the focus is on the baby and the parents sort of like left in the dust and forgotten about. And so, you know, the care of the baby is very important, but the care of the parents is very important. Anyone who's supporting the child's care needs to be in a good place so that they can provide care. So making sure you're checking in with both parent and baby, assessing for depression, talking about contraception, which usually is happening prenatally and can happen in the hospital. A lot of people can receive whatever it is that they need to space or prevent pregnancies while they're still admitted, and then supporting breastfeeding, whatever someone's feeding goals are for their child. So these are some of the things that we've already, some of the things that we've already mentioned in this talk, the pregnancy to recovery. So these are resources both during and after someone's pregnancy and during that early newborn time. So the UW Addiction Consult hotline can also be made available for patients who maybe there's a tricky situation with, you know, managing pain and managing their opioid use disorder. There certainly are resources if people have questions. And another, I guess, point to just mention is that, and this comes up sometimes with insurance and ability to get medication covered, but so Subutex or buprenorphine alone is what we're currently using during pregnancy. Once someone has delivered, whether they are breastfeeding or not, they can switch back to your standard buprenorphine, naloxone, Suboxone. So that's just a good thing to keep in mind, as it oftentimes is, there's less red tape around it for coverage from insurance. Did you have any other comments you wanted to share, Dr. Atluru, just about these resources and your experiences with them?
No, the California Perinatal Quality Care Collaborative is actually what most of the country is using. But otherwise, the Medical College of Wisconsin also has a Periscope project, which you can call to speak with a psychiatrist that specializes in pregnancy. So yeah. And then I think, what is our next one? I don't know what our next slide is.
Oh, this is just
yes.
yeah, some
Yes,
other
you
resources.
could talk about this. Yes.
Yeah, this is just a really helpful book, I think, for anybody who's providing this care. If you're part of a team, helpful to have it available to everyone who's on the team, as it does troubleshoot common issues that can arise and other questions that can come up. So I think with that, yeah, let's talk about this really quickly, and then we can get to people's questions. So these are just some, this is actually came from Dr. Atluru, but just in general, like attitudes, I think it's good to agree that this is the way we are going to act as professionals and as just compassionate individuals in the world, in the way that we interact with other people, particularly those who have use disorders. So speak with integrity, be impeccable with your words. So have your yes be yes and your no be no. And we're not, I think sometimes patients can feel like they're judged. And so speaking in a way that's very clear and forthright allows patients to not feel that way and to then have greater trust. Not taking anything personally. I think we've all experienced days where someone's having a rough time, rough day, maybe says something insensitive. It's usually not you, it's something else. And so being able to just respond back with neutral language when maybe someone's not feeling at their best. Don't make assumptions. So asking questions if something's not clear and making sure that you really understand your patient well, and then do your best. I think that's pretty self-evident, but providing the best care to patients. I think people can tell when they're receiving truly excellent care, and it matters to them because it acknowledges their dignity in ways that many of these patients haven't experienced previously. So these are some references. I do want to get to some of the questions. So if other people have questions they want to post on the board, that would be lovely. And then I just was looking here at Heather's questions. Are there training programs for affiliated professionals to support pregnant and postpartum folks and families? So I think that there can be lots of different answers to this question. I'll start, and then Dr. Atluru, you probably have more information about this. But one of the things that, at least within Access, that I think can be really helpful is we have an integrated behavioral health program. And so oftentimes behavioral health providers and those that help to support people in their recovery are present with people during and after their delivery. And then that there are trainees that go through that program. And so they end up learning sort of how to do this care. I would love to hear your perspective on other programs that you're aware of, Dr. Atluru, or others too.
I think Becky Foss may be a good person to ask about that, because Becky, you got trained as a doula and I don't actually know what program you went to. So maybe Heather, if I can maybe ask Becky to answer your question.
I'm happy to answer any questions. The program that we went through at Safe Communities was a doula that was offered in Madison here. And it's just offered another way to be supportive to the women that we are working with, meeting them literally where they're at and helping them with their goals and their pregnancy. And it's really amazing to have this team with you and Miss Caitlin to really foster those relationships and have for some successful pregnancies. And happy moms make happy babies, and happy babies make for happy moms. It's kind of how it works together.
And Megan, you may have some more information. I don't know of any specific programs that are for pregnant people combined with peer recovery training and doula training, but I think there's one in Seattle through Swedish, and Dr. Vanya Rudolph is the one I think that is affiliated with that. And then just going back up, I think Heather asked about outpatient programs for pregnant people and families in southeastern Wisconsin. So the Waukesha program, like I said, the family medicine program is integrated in Waukesha, Wisconsin. No worries, Heather. I put their information here, but they are a great resource. They kind of have behavioral health, they have a nurse practitioner, and they have the family medicine continuity model as well. So they do a very nice job, at least in southeastern Wisconsin, Columbia St. Mary's. And then I think Dr. Miller brought up a point about why do you think so few OBGYNs have their waiver? I think it's probably underdocumented. And I also think family medicine just has fallen into this work. And so we partner a lot with our obstetrical colleagues. There are a lot of them that are interested. It's just kind of how the evolution of all the programs have been. And so here it's kind of a shared program. Some of the maternal fetal medicine, which are the high risk perinatologists, some of the OBs and myself and others, we all partner together. But I think traditionally it's about, I would say, like a 50-50 split between our department and OB, at least here. Where I trained in Oregon, it was 95% of the care of anybody with substance use disorder was provided by family medicine in Oregon. And that's the same for Washington and parts of California. And I think it's just how it's been.
Yeah, and I think I should have rephrased it. Why are so many family medicine providers providing this care? And, as I'm hearing you talk, I just think that it's just such a unique role, right? Where you have that connection and then also being able to take care of that baby. So it's thinking of then having to go to somebody else for OB, somebody else to get your buprenorphine, and then another third person to bring your child to go as a pediatrician, and explaining your story with judgments and staff putting people's different opinions there. So I just think it's really such unique care, and just not enough people are doing it. It makes me want to do OB hearing you guys talk for a little bit.
Allison's laughing because I helped
That's
for
awesome.
one of her patients, but yeah.
The thought of doing OB, it's really, I do think that patients are very lucky that come into your care. I was also wondering if you notice, if patients, or if studies have shown that if people find out that they're pregnant, are they more willing to do better in care if they have a positive pregnancy test, in becoming abstinent from drug use, or does that make a difference? I don't know if that's ever been looked at.
I'm not aware of studies to that effect, but I do think that a lot of these folks are people who just don't have a lot of contact with the medical system, especially for someone who is actively using. So for someone who's using, not in contact with the medical system, and then to all of a sudden have very frequent contact, that those early entry to prenatal care visits, and even once you're kind of settled in your prenatal care, you're seeing someone at least every month, if not, more often, and then even more often than that, later on in pregnancy. And so I do think that it's an opportunity, certainly, because of, that invitation. It's like an invitation into recovery.
Yeah, that's great.
And I will say some of the things that are going on, I can't speak to all the places throughout the country, but I know that some of the OBGYN residents here have lamented that they have gone through and received their waiver, but then the faculty staff that they work with aren't all waivered. And so then it can be challenging to provide this type of care when the person who's supervising you can't actually supervise you doing it, you know? And so there's been a push within the Department of Family Medicine to really ensure that there's, ideally, every faculty member is going to be waivered to provide buprenorphine. But if not, there's at least at each clinic a faculty champion so that no resident is denied the opportunity because of inadequate supervision. So certainly we're trying more and more to expand.
I think the other important thing too to highlight is there are people from around the state who have graduated from various residency programs, which is kind of how we do our training. One is Dr. Ezra Lyon, who graduated, was he the same year as you, Dr. Regner? No, okay.
2020.
Yeah, he is actually up in Wapaka. I get Wapaka and Waupun confused. And he is very interested in providing this care. So I'm sending a lot of patients his way that have delivered, because that's the other thing is there are a lot of people who have to come to Madison or Milwaukee to have their babies because their hospital, they're small, there are not a lot of delivery hospitals, and that's a whole different talk, 3 talks. A lot of them are closing down. They may not have the resources to help care for, to do the highest quality evidence-based care, whereas Dr. Regner and I are lucky enough to work at Unity Point Health Meritor, which is affiliated with UW, which is the busiest delivery. We not us, but we have up to 5,000 deliveries a year. So it's very common that we see this here. Whereas elsewhere, it may be 1 or 2 people potentially per year, if that, or not. What other questions? You have a captive audience in us for another 3 minutes.
So sometimes we'll hear from our peer support providers that people they're working with who are pregnant are really worried about the birthing process, talking to their doctors. I know a lot of the time we hear a lot of fear that they're going to be offered opioids during the process. And unfortunately, their fear a lot of the time is it comes to fruition. So do you have any support tips from our providers who are working with people who are worried about that process?
Yeah, so that's always a tricky question. So yes, it's very interesting. So I always ask the patient, what are you worried about? And that's kind of how I started off, where they're like, we don't want any opioids in labor. And I was like, okay, help me understand what you're worried about. Help me understand kind of where you're coming from, because I think there's a lot of misconceptions around opioids in labor, even amongst anesthesiologists. There's some, I think the biggest thing I ask patients is help me understand where you're coming from. And the other thing I do is I always have them work with our doulas if they're willing, just because then we can make a framework and a birth plan. And Meritor has a generic 2-page, it's available in different languages, birth plan. And it actually has a space that says how I want to be asked about pain. And there's kind of different options. And I actually like that because some people want to be asked about their pain and some people don't. I approach it as if you're on buprenorphine or methadone, we only have options for IV opioids. They usually are not as successful as an epidural in helping control your pain. And there are options for you. We have to give you higher amounts to override the methadone or buprenorphine. But the other thing I always ask people, let's say they went to C-section and they're getting opioids in labor. We work with our OB colleagues to do pain control other than opioids. So there are blocks, like nerve blocks that the that the OBGYNs and anesthesiologists can do to block some of the nerves that may cause the pain. Some people from around the country leave the epidural in for 24 hours. We split your buprenorphine or methadone dose. So those are all the different things. And then we add a very strict kind of taper regimen and said, because if you actually look at the research and the data, we overprescribe opioids for postoperative pain. And most people, even with substance use disorder, only need 1 to 2 days of opioids even post cesarean. And some people don't. And so you have to have that discussion ahead of time with your provider if you feel comfortable. That's the thing. Like, I have the discussion and I'm like, okay, so this is what our pain plan is going to be. What I do is I copy it, I work on it with the patient, I copy it into their chart, I send it to the OB who's going to do the C-section, I copy it into the different chart, I make sure everybody knows the plan. And that's the only way I've seen it be successful. Every other way has not been successful, but that's just what I do, and I'm crazy. But I also, again, I came from a place where we did not use a lot of opioids post-operatively. We had access to nitric oxide for pain management, and our anesthesiologists were a little more flexible in terms of keeping an epidural in for 24 hours and doing blocks.
I think if recovery coaches are looking for something to be able to share, like because if someone's just saying, I'm worried, I think it is helpful to even just to have that knowledge that these medications are safe and your doctors aren't going to like let you, use something that's inappropriate that won't jive with your current, treatment. So if some of the concerns just come up from, is this even safe? Like, is this safe? Can I get this, this medication? One of the benefits of being in the hospital is that it's a very controlled environment. Everything's being monitored, and yeah, it is safe. So.
Does
And I
that
don't know if-
help, Megan? Sorry.
Sorry, I didn't know if I could just speak a little bit to that, in the sense that's a role that's important with peer support, and then the doula, and then having these open conversations with the physician. I think so oftentimes that I'm trying to be mindful, but I can set myself up about an experience that I haven't had yet just by thinking the worst that's going to happen. And what I've found is so wonderful is by having these relationships and these open conversations, it kind of helps, right? We're not planning, we kind of talk sometimes about the worst case scenario just because, and then they ask questions about, well, what would that look like? And then, it kind of helps foster this relationship and this environment that they kind of know what it's going to look like going into. And that's part of the shame and the stigma. No question is ever looked at as, we want you to have these open conversations. So that's just part of the process.